about a very interesting theme today, and we are starting the journal club, which will be on a monthly basis to cover the key aspects of pediatric endocrinology, especially the research part. So as part of the first session, we'll be focusing about 4 articles. 3 of these are about new therapeutic options, which are available in different scenarios. And 1 is about the diagnostic issues. So we'll try to critically analyze as to what really is being published in the journals is one part, and whether it will change our practice or whether it should change our practice now or in future will be the key themes which we'll try to focus on. So whenever we do a literature analysis, basically we have to look at a scenario as to whether we need to change our practice or not, because that's the most important part, and this is what we'll be focusing about. We have to look at the validity of a particular study, whether it's valid or not, whether that particular study is generalizable or not. So the main aim basically is to see whether we can change our practice based upon a study. So that will depend upon whether the study is valid or not, whether we can generalize that study or not, whether it is a novel work or not. So we see that there are so many papers which are published every time so much research happens. Only a small percentage of them actually change the actual practice. So we have started off with this grand round. You all can go and have a look at our website, learning.growsociety.in, which covers a lot of pediatric endocrine resources, including programs, training programs of fellowship and diploma, which are available. We do a lot of our webinars, including the grand rounds, postgraduate lecture series, and now the journal club, which is there. There are publications which you can access, and this is the mobile application which can be talked about congenital adrenal hyperplasia now. And the major problem in CAH, we all know, is we have to balance between too little and too much. So that hydrocort dose is too little or too much, and that causes problem. If you give less dose, you will have early puberty, you will have bone age acceleration, you will have symptoms. If you give too much, you will have glucocorticoid toxicity, bone health will come down, obesity may happen. So there are always ways in which you can improve it. So Dr. Vibha will talk about this very interesting new concept, which is again from an adult perspective about CAH and how the results and new therapy can change that. So Dr. Vibha.
I'm here to present a new molecule, tildacerfont. It is basically a CRH1 antagonist, and this has been used in adults with the classical congenital adrenal hyperplasia. And actually, this is studied in only in a phase 2 trial, and the studies are still going on this molecule. Basically, why do we need this molecule? This is important because we still have a hydrocortisone and fluorocortisone for the treatment of congenital adrenal hyperplasia. But as sir has just mentioned, in some patients the requirement goes high, like in puberty and adolescence, when the requirement of hydrocort goes high, and we really need supraphysiological doses to suppress the excess androgens. And in that cases, the role of this CRH antagonists come into place. So the main story behind the development of this molecule was to reduce the excess androgen production, and which will help us in the reduction of the glucocorticoid dose. So this was the main reason for the development of this molecule. And as we all know, the side effects of this higher doses of the glucocorticoids, and they are the higher doses causes the stunted growth in the child. They causes type 2 diabetes mellitus. They cause obesity, osteoporosis, gastric ulcers, and they cause cardiometabolic diseases. So in this condition, this molecule has really a great potential. We all know that the 21-hydroxylase deficiency, the main management that we do is we give hydrocortisone and fluorocortisone to do the replacement. But we have other options to manage these conditions, like as we have modified release of hydrocortisone. What are these? The tablet comes in 2 layers that causes the sustained release of the hydrocortisone, and that maintains the level of hydrocortisone in the blood. Another option is the aromatase inhibitor. The bones of the CH patients is already advanced, and they are more likely to fuse soon in the in the early childhood. So the aromatase inhibitor, what they do, they give some time to the bones to grow and give some time to gain height. And when we start the treatment in CH in the boys, the testosterone level goes and it triggers the central precocious puberty. So the role of generous analog comes here, and now the main hero of this story comes the CRH receptor antagonist, that is the tildacerfont, which blocks the CRH receptor and it reduces the excess androgen production.
So why do you need a higher dose in CAH compared to adrenal insufficiency?
So because we have to suppress the excess androgen production, and in adrenal
target ACTH in primary adrenal insufficiency.
Sir, in primary adrenal insufficiency, target ACTH is around 2 to 3 upper limit.
If you allow that sort of ACTH in CAH, a lot of these unrequired compounds will also be produced. So that's why you need to have a higher dose. And what is the usual difference in terms of the percentage or the amount of dose? How many milligrams per meter square per day?
So for the primary adrenal, we require like 10 to 15, and for CH, for the primary adrenal, we require this 10 to 12, and this CH require 10 to 15.
So we are talking about this 3 milligram per meter square per day difference in terms of hydrocarbon. That is the whole picture. So for that, we are doing a new treatment. So this is something we need to understand why we are thinking of that treatment. The other option which people said, as you said, is remove the adrenals.
Remove the
adrenals.
adrenals.
Is not doing any good. Let's remove the adrenals also. Yeah.
There is another option, Arbitron. It is a 17-hydroxylase inhibitor. What it does, it blocks the androgen and the cortisol pathway, and it increases this mineralocorticoid pathway. But in this CH, the mineralocorticoid pathway is also blocked, so it will help the suppression of this excess androgen. And the newer compound is nivalimab. It is basically a cortisol synthesis inhibitor, and it will inhibit the steroidogenesis process overall. So these are the treatment options that we can use in the CH patients. So now coming to what is tildacerfont is, it is basically a selective non-steroidogenic oral compound. It is a second generation compound, and it basically reduces the overproduction of the androgens. It is given at night before the dinner, because if it is given along with the fatty food, it increases its absorption. So coming to the study, what study is and how what were the patients, what were the subjects involved? It was basically a open label phase 2 trial, and it was performed in the multicenter. The aim of the study was to assess the safety and efficacy of the tildacerfont in the adult CH patients. And they included all the patients who were diagnosed with CH greater than 18 years, male and the female, whose 17-OHP were greater than 800 nanogram per dl, and who were on a stable regimen of glucocorticoids for greater than or equal to 30 days. And they excluded the patients who were pregnant women, nursing women, and who had previous bilateral adrenalectomy, who had psychiatric disorders within 6 months, who were taking rosiglitazone or any strong CYP3A4 inhibitor.
So basically, they have an uncontrolled CAH for the
Yes,
one
sir.
criteria. So when you say 800 nanogram per dl,
this is huge.
So what is our target?
We keep it below 10, sir.
So 10 is 1000 nanogram per dl. So
10,000.
it is somewhere around the same target. We're talking about 3 times the upper limit.
Now see how the study was performed. Basically, in this trial, they performed 2 studies. In the first study that named as 201, they enrolled 24 patients. It was they gave multiple doses. Like we can see, for the first 24 days, there were 3 cohorts, A, B, and C. In the first cohort, they gave 200 milligram for 14 days, then 600 milligram again for next 14 days. Then they escalated the dose to 1000 milligram for the next 40 days. Then they take the sample at the baseline. They take several samples at the baseline day 1, and at the end of the 14 days, in the study 202, they enroll the patients who have completed the study 201. They take the same patients from the 201 and they give single dose of 400 milligram for 12 weeks. And
this is basically a drug finding trial.
Trials.
So we are trying to understand there is a new therapy available, but this is not the final trial. This is more of a dose finding.
Dose finding, because this is in the phase 2 itself.
Yeah.
So now what they have found during the study, they found that based on the baseline androstenedione and ACTH, those who have the values greater than twice of the upper limit of the androstenedione, they classified it into the poor disease control, and those who have levels below the twice of the upper limit, they classified into good disease control. So in the study 201, in the cohort 1, 10 participants were enrolled. In the cohort B, 9 participants were enrolled. In the C, 9 participants. And in the study 202, 11 participants were enrolled. What they found that they found some drug-to-drug interaction of dexamethasone with tildacerfont. So they removed the patients who were taking dexamethasone. Now, what they have found, the patients who were taking higher doses of glucocorticoid, they were on a good disease control. Their disease were much controlled, and they were taking like 36.3. They were taking huge amount of
in adults, you need much
higher doses of.
So let's assume a body surface area of 1.7. You're talking about 20 to 22 milligram per meter square per day. And people who are on 24 are around 15. So what they're trying to say is that 15 milligram per meter square per day probably is not good enough in this criteria. So that's why they are on a much higher dose in that perspective.
And what they have observed after giving the molecule, they found the effects on the biomarkers. Like in the poor disease controls, the levels of ACTH, 17-OHP and androstenediones all were reduced after giving the tildacerfont. And there was no dose response curve. It means after giving either 100 milligram, 200 milligram, 600 milligram, or 1000 milligram, there doesn't found any.
In fact, you are saying that at 1000, the response is going off.
Yes, sir.
Probably having a saturable kinetics. So after a level, it goes down. So even 200, 600 are 200 seems to be a very good.
Yes, sir.
Yeah. 600 definitely is okay, but 1000 is actually going down. So a higher dose may not be good enough.
And they didn't found any additional benefits if they give 100 milligram as BD. And they didn't find any benefit if they have given this 200 more than 200 milligram. And in the good control disease, they found that levels do not reduce much as compared to the poorer controls.
That is expected because already they are
good controls.
So how better you will make it? The issue there will be whether you can reduce their hydrocortisone dose. They are on 36, whether you can bring them down to 24 and still they are in good control. That will be the
and the study 202, what they found, the results were same like in the poor disease control and the good disease control. The levels reduced at a much lower level in the poor disease control, and the levels reduced to much, the curve is much flatter in the good disease control.
And as soon as you stop, it became high.
It rises up.
So it's a temporary effect, of course, as expected, but we're talking about figures down of around 40%.
Yes, sir.
So if suppose your level of, let's say 17 OHP was around 10 nanogram per ml, it comes down to 40, it becomes 6. So you are in a good control in that perspective. And then maybe you can cut down the dose a bit.
And what they have found, there was a large biomarker reduction over 12-week treatments if they were on a stable glucocorticoid regime. And they also found effects on the TARTs. And after 6 weeks of treatment, they found that there was a 23% reduction in the TATs. The size reduced from 1.43 centimeters to 1.28
This is a
centimeter.
very clever way of putting it, because you expect a better benefit in TAT, because this is directly mediated by ACTH. If you are blocking ACTH production, of course, TAT will come down. But the other overall control, whether it's happening or not,
they haven't mentioned. There were no side effects mentioned, observed in the study. And they concluded the study as it is a well tolerated and a safe study. And the mean levels of ACTH, 17-OHP and endosteroid were reduced in the poor disease control patients. And in the study 202, they concluded it as the continued reduction could be achieved with long-term therapy, like for the more than 12 weeks. So the impact of the study is like there is definitely a need of treatment options in CH because of the side effects of the supraphysiological doses in the patients. But the drawback of the study is like they have used a very small sample size, like 11 and 24. And they haven't followed it up for a long time. They have just a follow-up of 12 weeks. And they haven't mentioned about the clinical outcome of the drug. What will affect, whether it will affect on the bone health or whether it will on the metabolic outcome.
Not really too early. So what they have said is that lower dose is reasonable, and probably 400 milligrams is what they want to continue for a long time. That was the main aim. It is too early to comment about everything. So probably at this point of time, you cannot say that there is a need for change that, but there is a new drug which is available. It will take long time. So what we try to do through this journal club is to look at 4 very relevant issues about how things should change. So for the first paper, we can say that if somebody is obese and has a borderline level of growth hormone deficiency, think twice before labeling them as GHD. Second paper, hypoparathyroidism PTH role at the moment is not giving too much of benefit, and probably it will be too much of a task to give it at the moment unless, as Dhwani talked about, a closed loop sort of a scenario is developed. With regards to the use of CRH receptor antagonist also, it's too early, but this could probably and potentially have a benefit of reducing the dose by maybe 3 to 4 milligram per meter square per day. And finally, liraglutide, definitely if there is diabetes, you will be thinking about that. And now with semaglutide, again, that will be a good option in that perspective. But at the moment, in childhood and adolescent Prader-Willi syndrome, it is of limited benefits. All of you can go and have a look at our website, the courses and the mobile application.